Hello and welcome to the third and final event in the systems stream of the 2022 Healthy Working Lives seminar series. In this series of seminars, we've been describing findings from the transition study. This is one of the large studies we're leading here from the Healthy Working Lives research group at Monash University. Before we begin, I'd like to acknowledge the traditional custodians of countries throughout Australia and their connections to land, sea and community. I pay my respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I'm joining you from the lands of the Wurundjeri people of the Kulin Nation. My name is Professor Alex Colley. I'm the Director of the Healthy Working Lives Research Group at Monash. I'll be your MC for today's event. Today's seminar is titled, What Healthcare Do People Receive When Workers' Compensation Ends? And our speaker today will be Dr. Michael Di Donato, also from Monash University. Michael is a postdoctoral research fellow in the Healthy Working Lives group. His doctoral studies explore the interaction between income support systems, such as workers' compensation, and healthcare for workers with low back pain. Dr. Donato's research seeks to understand the impact of policy changes on healthcare service use and social welfare outcomes in compensable workers, to create rapidly reportable indicators of quality of care delivered to workers with low back pain, and also contributing to the development of a large-scale health service research database. His areas of interest include social welfare and income support systems, healthcare delivery and quality for low back pain, and how system policy influences worker disability and recovery. There'll be a question and answer session at the end of the seminar today, but throughout the seminar you can submit questions via the Ask a Question button below your live stream. I'm going to hand over to Michael now, who will begin by giving some background to the transition study and then present some new findings on general practitioner, physical health and psychological health service use in people with long duration workers' compensation claims. Okay, over to you, Michael.
Hi everyone, and thanks for the introduction, Alex. It's good to be here today to talk about the third report in the transition study, health service use after long periods of workers' compensation. So before we get started, I'd like to thank a number of people and organisations who are involved in the transition study. You can see them all here, in particular Dr. Tyler Lane, Dr. Daniel Griffiths and Professor Alex Colley, who you just met, as well as a number of organisations, the State Insurance Regulatory Authority of New South Wales for funding and data provision, the Centre for Health Record Linkage, the Australian Institute of Health and Welfare, the SACS Institute, the Department of Health, Department of Social Services and New South Wales Department of Health. I should also note that the study receives funding from CIRA of New South Wales, but the views expressed in this presentation and our report are those of the authors and may not reflect those of the study funders. If you'd like more information about today's presentation and things we're going to talk about, there are a number of documents available online. The study protocol is published in the Journal of Population Data Linkage. Reports 1 and 2 are available online. Report 3, which we'll discuss today, will be available online shortly. So Australia has a pretty complex jigsaw of work disability income support systems, depending on your kind of disability, how long you're off work or how you are disabled. Sick leave is the typical short-term disability system. We take a bit of sick leave if we're feeling unwell, and then we typically return to work. I did just last week, as you may hear from my voice. But there are a number of other systems as well. So workers' compensation is in place for those who have a work-related injury, but this is often capped. Some of these systems are often capped at a certain amount of time. So workers' compensation may be limited to 2 years worth of payments, at which point people may need to find income support from another system. For example, the Centrelink is the Commonwealth system. It's the Commonwealth safety net for income support, but there's also an array of other systems such as life insurance or superannuation withdrawals, a variety of others. So, but what happens when income support stops? Well, you could return to work and earn wages, which is typically what happens with some short-term disability, Or you could transition to alternative income support systems such as Centrelink, as I mentioned. There's the Job Seeker, which is formerly known as New Start Allowance, a disability support pension, and several others. And this was the topic of the transition study report 1. You could also seek or use alternative financial support such as partner income or your own assets and savings, or even life insurance. And what about healthcare? What about healthcare when income support systems stop? For example, workers' compensation does provide funding for reasonably necessary healthcare. Well, you're usually eligible for medical coverage, as I mentioned, under workers' compensation after income benefits end. Typically, this can be for about a year after income benefits stop in New South Wales. It's 2 to 5 years, depending on your assessed capacity. There's also healthcare funded by other systems, such as Medicare or public hospitals in Australia. And really the question is, what healthcare do you use? So the broad question of the transition study is what happens to workers with long duration workers' compensation claims when their workers' compensation benefits stop? The specific question for this report was, what was the impact of the Section 39 legislative amendments on income support and healthcare for New South Wales workers with long duration claims? So in 2012, the New South Wales government had put through the Workers' Compensation Legislation Amendment Act. This is in response to the position of the Workers' Compensation Scheme. There was a projected $4.1 billion unfunded liability, which would lead to an increase in 28% increase in employer premiums. So there was a major scheme reform with many changes to reduce scheme expenditure, including restricting eligibility. There are also changes in access to benefits and funding for services. And Alex has a paper on this available in Occupational and Environmental Medicine. Section 39 of the Act specifically stated that from December 2012, all income support would be capped at 260 weeks maximum duration. That's 5 years. There are exemptions made for people with whole person impairment greater than 20%, and exemptions for people employed as firefighters, paramedics, police officers, and coal miners. The consequence of Section 39, or this Section 39 of the amendment, was that from December 2017, income support stopped for a group of approximately 4,000 people with very long duration claims longer than 5 years. Access to healthcare continued for these individuals for 2 to 5 years, but we're going to see what happened to them. So if you think about this group of people, their claim was accepted, they had pre-reform benefits to services, and then the legislative reform came in place in 2012. They had transitional income support for the next 5 years. There were certain aspects of the workers' compensation scheme put in place to assist them. Income support then stopped in about December 2017. And so then the question is, then what happened to their income support, to their hospitalisation, healthcare use, medicines use? What happened to these individuals? And so this is where we needed to do what's we refer to as some data linkage. So once somebody's in the workers' compensation system, we can see what services they might receive or what benefits they might receive from workers' compensation, but we don't really know what they're receiving outside of that system. So with data linkage, we can link multiple data sets about an individual to understand what the whole of their receipt of benefits and services are. So as you can see, before, during, and after the claim. So data linkage involved 5 organisations, including the State Insurance Regulatory Authority of New South Wales, which is the workers' compensation data. We also worked with the Australian Institute of Health and Welfare, the New South Wales Centre for Healthcare Record Linkage, and the Sachs Institute. And these organisations provided, they executed a detailed protocol to extract and link workers' compensation, Centrelink, Medicare, and pharmaceutical benefits, hospital and emergency department data sets, and all while maintaining privacy and security for these data. So now we had this data set of linked data from multiple sources so we can see what's happened to these people. So in our sample, we had 3 groups of people, with the Section 39 group, which was those aged 18 to 67, who had 260 or more weeks of income support payments and were affected by these Section 39 amendments. The injured control were injured workers with long claims, but those whose claims did not cease due to Section 39. So they had at least 104 weeks of income support payments, but their claims didn't end due to Section 39. And the community control group was matched to the Section 39 group on age and gender and residential location, and drawn from the general New South Wales population. So we refer to two periods of time throughout the transition study, the pre and post index period. The index date is the date of final workers' compensation income support payment for these individuals. For the community control group who were not receiving workers' compensation, this was assigned as the 25th of December 2017, which coincided with the median index date of the Section 39 group. So the pre-index period was the 12 months before the final workers' compensation income benefit, and the post-index period was the 12 months after the final workers' compensation income benefit. And this is a figure from report 1, which you may have already seen if you saw Alex's presentation, but this looks at fortnightly Centrelink payments for the Section 39 group with 12 months pre and post the index period. We can see the percentage of the group who were receiving various Centrelink payments. So using this kind of data linkage, we can get some really important insights. In fact, here we can see the large uptick in the percentage of people receiving fortnightly New Start allowance payments and various other payments as well. But what about health services? That's the focus of our discussion today. Health services are important to worker recovery. Health services are involved in both the treatment and administration of a worker's recovery process. So healthcare workers may be involved in certifying the capacity of a worker for ongoing benefit receipt and also treating the worker. Health services are funded as reasonably necessary by the workers' compensation scheme. That is, they're deemed reasonably necessary for the recovery of the worker. And healthcare services, treatment and other services constitute a very large portion of workers' compensation expenditure in Australia. In 2019-20 in Australia, that was about $2.38 billion, which is about 24% of all workers' compensation expenditure. So in Transition Study Report 3, we sought to answer the questions: does the prevalence rate, volume and funding source of health service use in Section 39 group change in the year before and after workers' compensation ends? And how does this compare to a group of people with long duration workers' compensation claims, the injured control group, and a community group? So health service funding for workers' compensation in New South Wales could come from, like in many other states in Australia, four different sources. The Workers' Compensation Scheme, which is the state government, the Medicare Benefit Scheme, which is Australia's national health insurance scheme, private health insurance, which a lot of Australians do have, or also out-of-pocket expenses. Out-of-pocket expenses may also contribute where there's a gap in Medicare payments as well, just to note. In our study here, we have linked the workers' compensation payments and the Medicare benefit scheme payments. So we're looking at two sources of payments. Unfortunately, we didn't have access to whether somebody had paid for services out of pocket or via their private health insurance, but we estimate that the majority of health services are funded either by the workers' compensation scheme or by Medicare. We selected a prioritised group of health services to look at in this analysis. That were general practitioner services, psychological health services, such as psychologists, social work, counselling and rehabilitation counselling, and physical health services, that's physiotherapy, chiropractic or osteopathy. We selected these for a couple of reasons. Firstly, these services enabled us to compare funding from the workers' compensation scheme and the Medicare benefit scheme. Because Medicare doesn't fund every service. So, for example, there are a number of services Medicare might not fund that workers' compensation would fund as being reasonably necessary for worker recovery. And we also know that these services are relatively common among both the general population and injured workers. So all our services data were cleaned and harmonised together. So ultimately we could say, here's a GP service on a given date. It was funded by Medicare, or it was funded by workers' compensation. Or here's a psychological health service, for example. We measured a number of outcomes in this study. We measured service prevalence, that is the percentage of people in each group who had at least one service in the pre or post-index period, the service volume, that is the total number of services, the service rate, the number of services per 100 persons in a group, services per person. So if people had a service, how many of that service did they have? And the service funding, which is the percentage of services funded by the workers' compensation scheme. So, for example, if 50% of services were funded by workers' compensation, the other 50% were funded by Medicare. Excuse me. So if we look at our sample, we had a sample of 15,689 persons. Most of these people had claims physical compensable injury. There's about 2,700 people in the Section 39 cohort, 2,800 in the injury control, and 10,000 in the community control. There's a little bit more information in this in the report on the demographic information about these individuals, but just as a glance, that's the kind of sample we're working with in this report. There are a total of 420,000 services 12 months before and 12 months after the index date, so the 24 months around the index date. And the majority were general practitioner services. So as you can see, of the total there, general practitioner services are about 85% of all service volume. We'll get into a bit of why that might be later. We should note that these services are services where there's been a patient interaction. So there's an interaction between the practitioner, the healthcare provider, and the worker, pardon me. And it doesn't include services like report writing or other miscellaneous things that some healthcare providers might be required to do. So only patient interactions. So if we look at general practitioners first, we can see that almost all people had at least one GP service 12 months pre and 12 months post-index. The post-index date, the lowest prevalence that GP services fell to was about 96%, but a lot of people had GP services, and you can see the rate of GP services is quite high. It remained quite high pre and post-index in the Section 39 group, but you can see a more substantial drop in the injured control group post-index to pretty much community control rates of GP services. The median number of GP services between those who had GP services remained similar in the Section 39 group. But again, as you can see in the injured control group, the median number of services dropped to almost the same as the community control group post-index. So basically those in the injured control group, their GP service utilisation dropping to community levels in the 12 months after workers' compensation benefits ended. If we look at these figures here, I'll just orient you to these. This is a time series figures. The first figure there is the rate, the monthly rate of services per 100 persons in each group. And the second figure is the percentage of services funded by the workers' compensation scheme from 0 to 100% on the y-axis you can see there. So the blue line you can see is the Section 39 group, which decreases slightly over time in rate and also in funding, in the percentage of funding, to below 50% of services funded by workers' compensation. You can also see the Section 39 and the community control group have a bit of a dip in the first, just after zero there. That's approximately the Christmas New Year's period. If we remember, the index date for most of the Section 39 and community control group is the 25th of December 2017. And we can see that the rate of services for the injured workers group dropped down to that community control level. And the percentage of services funded by the workers' compensation scheme also drops away fairly substantially post-index. If we look at psychological health services, about 21% of the Section 39 group and almost the exact same proportion of the injury control group received a psychological health service in the pre-index period. The rate of psychological health services in the injury control group dropped more than the Section 39 group in the post-index period, as you can see here from the top figure, still slightly more elevated than the community control. The median number of psychological health services in both the injury control groups, both injured worker groups, rather, was higher than the community control as well. So even in the post-index period, the number of services for the psychological, for the injured worker group remained above the community control. If we look at the time series again, we can see some more substantial changes to the injured control group around the index date, although the rate of services did appear to be decreasing in the pre-index period anyway. We can see those big dips again around the Christmas New Year period for the Section 39 and community control groups. Importantly, we can see that the percentage of services funded by workers' compensation for the Section 39 group remains relatively stable, but does drop away a bit more in the injured control group. And also, sorry, I should say the rate of services for the Section 39 group remains relatively stable. And physical health services, well, 25.4% of the Section 39 group and 27.5% of the injured control group received physical health services in the pre-index period. You can see it's a bit higher for the injured control group. The rate of physical health services in the injured control group dropped substantially post-index. As you can see, it's a fairly substantial drop in the rate. And the rate of physical health services in the Section 39 group remained relatively stable, remained elevated post-index. The median number of physical health services was completely stable, almost for the Section 39 group, both between pre and post-index periods. And you can see that drop again to almost community levels in the injured control group. And here again with the timing graphs, the 12 months pre and post-index, you can see a fairly substantial decrease pre-index and an ongoing decrease post-index for the injured worker group, injured control group rather, and a relatively stable rate for the Section 39 group. The percentage of funding percentage of funding by workers' compensation remained relatively high, which we will discuss in a moment, but we believe there's a reason behind that. But as you can see, it remained relatively high for the period pre and post index. Excuse me. So our main findings. Well, the rate of GP, psychological, physical health services was for workers with long duration claims substantially higher than the community control group prior to benefit cessation. Those with long duration claims appear to have ongoing health problems and subsequent health service requirements, even long after their original injury or illness. It should be noted that this group of people, we're talking 12 months pre and 12 months post their benefits ending, but a lot of these people had claims of at least 5 years in duration, so it's a long time after their initial injury or illness. So health service use continued after benefit cessation in the Section 39 group, with only a small reduction in the prevalence and rate of services and the proportion of services funded by workers' compensation. These workers may not have recovered, or returned to work, but also funding for health services was offered for 24 months after weekly benefits ceased for both the Section 39 group and part of the injured control group. She'll explain that a bit more. The injured control group, because of their claims ended at various points in time, there were some legislative changes in New South Wales. For some period of time, so some of the injured control group, they were eligible for benefits 12 months after the income support benefits ended. They were eligible for 12 months of healthcare. For others, they were eligible, like the Section 39 group, for 2 to 5 years of healthcare after weekly benefits ended. So a little caveat there to why some of these health services may remain elevated. Workers in the injured control group experienced substantial decreases in health service use after benefits ceased. Absolutely. At least some of the workers may have recovered and returned to work, at least some of them, but it's more likely there were other factors that led to the reductions in health service use. So, for example, there was a reduction in administrative requirements. So if these workers were no longer eligible for income support benefits, they no longer had to get a certificate of capacity every 28 days from their general practitioner, which would therefore drive down the utilisation of GP services. There may have also been a misunderstanding of ongoing benefit eligibility from the workers' compensation scheme, and also potentially administrative challenges in gaining approval for ongoing medical services. So, for example, it may have been easier just to simply have something bulk billed through a GP rather than have it applied for funding reimbursement or funding from the workers' compensation scheme. The proportion of services funded by workers' compensation for both groups was lowest for GP services, followed by psychological health services, and, as you saw just before, physical health services. So GP services are highly accessible via the NBS with minimal administrative barriers. So there are, I think in our study we included upwards of 100 different GP service items in the NBS. So it's widely available in the NBS, whereas psychological and physical health services are limited in the NBS. So, for example, if you wanted to get physical therapy services or physiotherapy services, you would need a chronic disease management plan from your general practitioner, which would then enable you to receive up to 5 physiotherapy appointments funded by the NBS per annum. And if you remember, the median amount of services these people were receiving post-index was about 5. So it's about that amount that the NBS would limit people to. So it's much easier to get funding for those services as reasonably necessary through the workers' compensation scheme, which is why we hypothesised that the fraction of funding for physical health services was much higher for workers' compensation because of that access to services via the NBS. So the transition study has enabled us to look at some really fantastic gain some really fantastic insights. There's a lot of strengths to the study. We have a very large sample size. We're very fortunate to have linked data that can answer a range of questions about workers' compensation that no single agency or department can. The sample includes the matched community control group, which we can see is very important for comparisons to the injured control group in this instance. And data included on health services that are not funded by workers' compensation have not really been looked at before. That's one of the main limitations of some of the other studies that look at workers' compensation, is that the insight stops after workers' comp. We can't look any further, but in this case, we were able to. We were able to see that services funded by Medicare take up a large proportion of services funded to at least this sample. So what's next for us? Well, the receipt of Centrelink payments after workers' compensation ends, and the hospital admission and emergency department presentation reports are available online now. This report that we've discussed today will be available online shortly. Seminars for those 2 other reports are available on demand, and this seminar will be available on demand after today too. And in our final report, we'll be looking at the relationship between hospital and health service use and income support payments after benefits end. And with that, I might hand back to Alex for our Q&A.
Great, thank you, Michael. Thanks for that great presentation, and have a break and give your voice a rest. Thanks for persisting through your post-COVID cough. Good job. So now we've got a chance for a question and answer session. I'll just remind those listening that you can ask questions via the button below the screen, below your screen. So please, now's the time to get those in. I've got a few that have come through already that I'm going to ask Michael. The first one, Michael, you've sort of touched on this a little bit in your presentation, but I wondered if we could go into it in a bit more detail, because one of the major findings, the most dramatic change, was that real drop-off in service use in the injured control group. So can we just revisit what are some of those reasons for that drop-off, and which ones do you think are sort of most feasible?
Yeah, there could be a number of reasons for that drop-off. As I mentioned, it's possible some of those people have recovered and returned to work, so they no longer needed those health services. There's also some administrative requirements. So as I mentioned, at least for GP services, those people no longer needed the 28-day certificate of capacity after income support benefits ended. So they wouldn't have had to go to their GP every 28 days. So that at least takes out some portion of those services. And it's also possible that there were administrative hurdles, to receiving services. So it may have been easier for these individuals to receive services via the MBS, so something's bulk billed by their GP, as opposed to having to go through the number of steps to have it funded by workers' compensation. And also, it could have been that they weren't aware they were still eligible for a number of services. Workers' compensation can be a complex area, particularly for somebody who's got a long-term injury, and it may be that they were unaware that they were eligible for ongoing health services after their income support benefits ended.
Yeah, so it's probably some combination of all of those things contributing to that. And there's a couple of those things I think that we could potentially do something about if we chose to, like the last one that you mentioned. And I do wonder, it'll be interesting, and I haven't seen really any other information published in the research literature about people's awareness of eligibility for ongoing benefits when their income support ends. So that would be something that would be sort of interesting to look into a bit more, because what I think you described in the Section 39 cohort has actually remained relatively stable for most of the services that you looked at. So there's clearly that information is getting through to people in that group, but perhaps less so to people in the injured workers group. So related to that, question I have for you, which I've been wanting to ask for a little while, is what do you think would happen if we followed people for longer? So in this study, we've looked at people for 12 months post the end of their income support, and you've said that the legislation sort of allows healthcare to be paid for 12 months or 2 years or up to 5 years, depending on what sort of group you're in. But if we followed people for 2 years, 5 years, what do you think would happen to service provision, particularly service?
I think we would see that service provision drop away, the rate of service provision. I mean, we were only looking 12 months post their benefits ending. And I mean, for example, the Section 39 group and a fairly sizable portion of the injured control group were eligible for benefits for at least 2 years after their income support benefits ended. So we're only looking at the first little bit. I think over time, it's possible we would see the rate of services drop away, or at least the percentage of services funded by workers' compensation drop away. But it might take some time to actually see that trend. We would have to follow these individuals up for at least the length of the period of time in which they're eligible. And some of these people, some people are indefinitely eligible, depending on their whole person permanent capacity. But ultimately, I think we would see services tend to drop away, or at least shift to Medicare.
Okay, we've got a question from Ali Kalira. I hope I'm saying that right, Ali. Apologies if I'm not. Which is, why did you choose New South Wales to focus on?
Well, because of these legislative amendments. So it provided us with an opportunity to conduct effectively a natural experiment where a policy has changed, and it allowed us to follow up to see what happened with these individuals. And it was a fairly clear-cut policy change, which allowed us to, for example, have these index dates, for example, defined dates from which we know an event occurred, which was the Section 39 amendments.
Yeah, and the follow-on question from me then is, do you think we'd see similar results if we looked at other states and territories in Australia?
Well, yes, probably, but also some different results too. I think yes and no. I mean, Australia's each state and territory has, although all their workers' compensation schemes have the same objective, a lot of rules mean that they go about it in fairly different ways in managing their schemes and having differences in eligibility. It will be very interesting to measure in different jurisdictions. I feel like we would end up with some similar results, but probably a fair few very different results too. Yeah, I think.
I think you're right, and I think we know that, or we do know that sort of the duration of income support varies quite a lot from state to state or jurisdiction to jurisdiction. Although it does seem to be getting a little bit shorter as as these systems develop, but also the access to scheme-funded healthcare also varies a little bit. So, yeah, it's likely that we'll see the same patterns, but the extent of the change and those sorts of things might be quite different.
Yeah, and even things like there'd be several things. It's down to how each jurisdiction defines what healthcare is eligible to be funded. Some say healthcare is reasonably necessary. Others say reasonable and necessary. It would also be down to again, limits on funding. Some jurisdictions have a time-based limit. Others have a monetary-based limit. So that would affect any outcomes as well.
Yep. Another question that's come through is just about something you mentioned early on when you were presenting the findings about that about 85% of all the services we're looking at were for GPs, and only about 15% for the other two service categories, physical and psychological health. So why do you think that is? Why are we seeing so many GP services in this cohort and so little of those sort of allied health services?
A couple of reasons for that. Firstly, we're very far from, at this point in the study, it's very far from the initial injury or illness. So, we're talking about we're 12 months either side of an index date, where for the Section 39 group, most of those people that index date is at least 5 years from their initial injury or illness. So, psychological and physical health services, therapeutic services may not be, they weren't as prevalent, because while people may be chronically ill, there may be no clinical benefit to some of the services they might be receiving.
Yeah.
Even in the injury control group, claims of at least 2 years in length, that is still quite a long time, from injury date. So we would expect to see a much higher prevalence of those allied health services closer to the injury date. The other reason is the role of GPs. I mean, GPs are the centre point of most workers' compensation systems. They handle both, and also the centre point of most of Australian healthcare. GPs are the centre point for referral to a bunch of other health services, and also therapeutic services themselves. But also GPs in workers' compensation in particular handle administrative roles like the certificate of capacity. They are a communication point between the worker and the workers' compensation scheme. So it makes sense that at this point going forward, the GP is still the predominant service in this the group of services we see this far from the injury or illness. Yeah.
So again, it's sort of a mix of administrative and clinical sort of issues that are affecting the service use, isn't it? It's not just about the need of the workers for that healthcare service.
Yeah, that's right. It's not just about the worker needs physio or the worker needs a GP. There's a number of activities that these healthcare providers may be performing, and particularly for the GP, there's a number of things that have to do administrative and clinical.
Yeah. And do you think if we looked, just to pick up on one of your comments there, if we looked at the start of the workers' comp claim for these workers, we'd see a different proportion. I hear what you're saying is we should see much more physical and psychological therapy if we looked earlier on in these claims, because that's where the greatest treatment need is.
Yeah, absolutely. And we've seen this in other studies previously, where the service use peaks very early, close to the injury date, as you would expect, for all services, not just physical and psychological therapy, and then kind of tails off as time goes by, with people who have more chronic conditions who still require those health services, who require the ongoing use. And they're not using a great deal of services either. So as we saw in the presentation, the median number of services that people were receiving for physical therapy, for example, was 4 or 5 over 12 months, over a 12-month period, which is not a very high service utilisation. As I mentioned, it's in line with what the NBS would fund for a chronic disease management plan. So it's less intensive therapeutic physical health and probably more along the lines of chronic disease management.
Yeah, okay. Great. We've got 1 or 2 more questions in the few minutes left to us. One has come through that we always get when we present these sort of findings, so I thought I'd pass it along. And that is, what is the so what question? So what are the implications of these for the way we manage workers' comp schemes, so for regulators and insurers? So for instance, how can we use this information to design services for workers approaching the end of their income support period?
Yeah, so I mean, it's a good question. What do we do with this information? And I think it's about assisting workers at the end of a workers' compensation claim to understand, to review and understand what their ongoing health service needs and service needs in general are, and how they can be provided to them and in an ongoing fashion, or how they can be efficiently provided to the people who are clearly still, probably still unwell. And there are, examples of this kind of thing done in other jurisdictions. So in South Australia, they have the Reconnect program, which assists people who are approaching workers' compensation benefits ending with accessing services, not necessarily healthcare services, but other social services and other potentially income services, income benefits too. But I think it's about, identifying people whose claims are coming towards an end, and then identifying what they need in an ongoing capacity so they can be provided properly. Because at the moment, if health service benefits end, then that's 1 of 4 sources of services funding the workers' compensation scheme goes, and then you have to fund those services from somewhere else. So it would be good to understand, what people need and how they can be delivered to them in the long term after benefits end.
And you and I both had an opportunity recently to learn a bit more about the example you gave there, the Reconnect program in South Australia.
Yeah.
One of the things we haven't looked at, except with access to Centrelink income support in this study, we haven't really looked at access to other sort of social care services. So that would be a useful thing, I think, as well, maybe for another study, if we can go through the data linkage exercise again.
Yeah.
All right, that's sort of it for the questions. There's a couple of comments coming through. For instance, Richard Buchanan has said it would be interesting to compare long tail versus short tail schemes to look at health, sort of longer term health service use in, and I agree, it would. It would require us to get a couple of states and territories on board with this sort of work, which would be fantastic, but it is kind of time consuming. And then there's a couple coming through about access to slides. So yes, the presentation will be made available online by this platform, and also by our Healthy Working Lives Research Group website. If you search us up on Google, at Healthy Working Lives Research Group at Monash University, you'll find us and you'll be able to get the slides there. And also the report that Michael has mentioned, which has a lot more detail on this, will also be made public shortly by those sources as well. I think that's it for the questions. So I might wrap it up there, Michael. Thank you for giving us your valuable time today. Also wanted to thank all of the people that have logged in and listened today and submitted questions. This event actually concludes. It's the 3rd in our system seminar for the Healthy Working Lives seminar series. And it's the final one in a whole series, which have included about 14 or 15 seminars that we've been running this year. I wanted to give a big shout out to Cara Tyndall, our communications manager, who's been organising all of these and has done a wonderful job in the background. So thank you, Cara. You can read the reports from the transition study and all of these 3 seminars, as I've mentioned, on this transitions project via our website and also via the app that you're logged into, and also the other projects that we've been reporting on through this seminar series, our Compare project about return to work and our Driving Health project about health in truck drivers and transport industry workers are also available via those sources. If you'd like to subscribe to our mailing list, you can do that by following the link in the chat box as well. And that brings us to a close. So thank you all, and I hope to see you again shortly in another one of these seminars perhaps. Bye-bye.